Good morning and good afternoon to everybody. I'm speaking from Central US today, so early, and I appreciate everyone joining us at whatever time zone you're in. I'm Regina Rabinovich, PI of the MESA Alliance, and I'm here to simply introduce this MESA webinar. We are thrilled to welcome you to this session, which is a platform to amplify the voices of malaria endemic researchers. These webinars aim to bring together the malaria community of innovators and showcase the work of malaria endemic researchers. The sessions cover a range of topics from social science to entomology, through insecticide drug resistance, stratification, and genomics, just to name a few. And they will be available on YouTube following the session and through a link on the MESA website, so they become part of the living repository of leaders actually in malaria endemic regions. For this seminar, I'm happy to entitle Below the Target, Innovative Ways to Accelerate Increase in IPTp Coverage. I'm delighted to introduce our moderator, Professor Martin Meremikwu, a tenured professor of pediatrics and child health at the College of Medical Sciences, University of Calabar in Cross River State in Nigeria. Professor Meremikwu has over 15 years of experience in malaria research with expertise in clinical trials, implementation research, and evidence synthesis. He has served as principal investigator in several multi-center national and international studies with funding varying from EDCTP, the European Clinical and Developing Countries Clinical Trials Partnership, Medicines for Malaria Venture, WHO, TDR, and the Federal Ministry of Health in Nigeria. He has played a pioneering role in building capacity for systematic review of healthcare intervention research and evidence-based healthcare in Nigeria. He serves also as director of Cochrane in Nigeria. He has served on various national research and ethics committees, currently on the Scientific Advisory Committee for the EDCTP partnership. So let me turn this over to Professor Nwankwo, and he will introduce the speakers. Thank you. Enjoy.
Thanks a lot. Thank you very much, Regina, and for that those very kind words. And thanks everyone for joining on this very important webinar organized by MESA. Like Regina has already introduced, we will be looking at innovative ways of increasing the coverage of one of the very important interventions for malaria control, if you like, elimination in Africa and other areas that are affected. And this time we're talking about intermittent preventive treatment for malaria in pregnancy. We will be, discussing these topics, which are obviously going to be anchored by two experienced speakers today. We'll have Dr. Ogonna Nwankwo, who is a Nigerian public health physician with background in policy research and health economics. Ogonna also is quite versed in mixed methods research. He drew his postgraduate training from both the London School of Hygiene and Tropical Medicine and the London School of Economics. So today he will be doing the first talk, which will be looking at an effort in Nigeria to use lay persons to deliver intermittent preventive treatment for malaria and pregnancy at community level. Our second speaker will be Jenipher Mukolwe Angaha, whose topic will be introduced in due course. So if Ogonna is already on the platform, we will turn the stage over to him. He will have 15 minutes to discuss his topic, and we will ask everyone who's listening, you can put your questions on the checkbox, and then of course, we will allocate time to discuss all the questions. So I will invite Dr. Ogonna Nwankwo to please take the stage and present his topic. Over to you, Ogonna. Welcome.
Oh, okay, thank you, Prof. Good afternoon, everyone. Thank you for the kind introduction. So I'm here to present on the evaluation of the use of lay persons in community delivery of malaria intermittent preventive treatment in pregnancy in Nigeria. So as a background, malaria in pregnancy is responsible annually for the death of approximately about 10,000 pregnant women and 200,000 newborn. As of 2018, over 11 million pregnancies were exposed to the infection, and as a result, close to almost 1 million children were born with low birth weight. Some of the complications of malaria in pregnancy can be very, very profound, both for the mother and the baby. It can lead to things like low birth weight, congenital malaria, and others. And IPTp has been recognized as one of the major effective control and preventive measures for preventing malaria in pregnancy, according to WHO and others. However, one thing we find out is even in regions that have high malaria endemicity, like a lot of sub-Saharan African countries, that they have very, very low IPTp coverage compared to their ANC coverage, which is usually higher than the former. So the question is there any potential solution to this issue to improve the IPTp uptake and the IPTp coverage? Well, this is what everybody has been pondering on until quite lately, when there is an innovation and which is being implemented and carried out, which is the use of laypersons in community delivery of malaria intermittent preventive treatment in pregnancy. This is being carried out under the project that is called Tiptop, which is transforming intermittent preventive treatment for optimal pregnancy. So the Tiptop implementation is being carried out in 4 countries, which includes Nigeria, Democratic Republic of Congo, Mozambique, and Madagascar, in 3 subnational areas in each of those countries. And essentially what it involves is to use community people, ordinary people that are found in the community, to now distribute the IPTPs in the homes of identified pregnant women, at least for their very first dose, and then encourage them to go to the health facility to continue uptake of their IPTP. The project is being implemented by Jhpiego. So our study objectives, because what we carried out was an evaluation of this project that has been running since 2018, 2019 till now, which is now when it is closing off as a research project. So basically one was to assess the acceptability of the CIPTP in Nigeria, to understand the social and cultural context under which the project is being carried out, and to identify the barriers and opportunity for the uptake of the CIPTP. So in Nigeria, the work is being carried out in 3 subnational areas. Akure South local government in Ondo towards the west, Ohuku local government in Buyin state towards the east of the country, southeast of the country, and then Boso local government area in Niger state, which is carried out in the north. So each of these places have different cultural and contextual issues. So the study design we used was looking at it from the social anthropological perspective, which was, we're not really interested in numbers, whether it was the yes and no answers, but to just get the views of issues that may have emanated in carrying it out. And it was carried out as a longitudinal study that was carried out every other year. And thus far, we've carried out 4 field work. It was carried out using an interactive approach. And then the conceptual framework we used in doing the evaluation was from the socio-ecological model framework and the barriers and opportunity analysis framework. On the right side of the screen is an example of the socio-ecological model that we used. So this shows how the timeline of how the field work has been carried out in the past 4 years from 2018 till, just recently that we just concluded for the 2021 round of the data collection. So for our target audience, majorly it was the beneficiaries, which is pregnant women. We recruited women of reproductive age, community leaders, and others. Why in terms of the tools we used was things like the focus group discussions, in-depth interviews, and carrying out extensive observation at ANC clinics, when the community health workers were actually going around doing the distributions of the SP and also following women in their day-to-day activities. And then also through informal conversations with key actors and key stakeholders in the community. So using the socio-ecological model, the influential actors we found out that could help for women to actually receive IPTp, even using the community health workers, was at an individual level, was the pregnant woman, basically in terms of her knowledge and the level of autonomy she has in exerting decision. While the interpersonal level, what we found out was that the husband, mothers, and mother-in-laws were the key primary people that would influence a woman in making that decision. Having said that, of course, there were other people that were mentioned, like in some sites where we had, although in a minority, where we had things like fathers and father-in-laws, also were also people that could at that level influence women. Then at the community level, we had leaders of community association and even local leaders that were mentioned, all the chiefs, the obas, the people that were influential in terms of being traditional rulers, as well as religious leaders. Then interestingly also, community health workers were mentioned as part of them, and then traditional birth attendants. While at the organizational level, again, healthcare workers were mentioned and community health workers, while at the political level was the state law and the Ministry of Health and other political actors. Under the barrier and opportunity analysis, we looked at it under majorly these 6 frames of what were the perceived susceptibility to the diseases, perceived efficacy of the treatment, and social acceptability of the treatment, among others. So under the perceived efficacy, I'll just do a few of them, and then I'll go to the conclusion, given the time frame that we have for the presentation. Under the perceived efficacy of the treatment, what we found out was the majority of the interviewers perceive SP as effective for malaria in pregnancy. Now, because we took a longitudinal course, this has actually changed, because initially when the project was starting, as of 2018, a lot of the people, there was higher apprehensiveness around the SP, but over time, as the community health workers have moved around in the community, people now tend to perceive it as a very, very effective tool for malaria in pregnancy. However, the perception of the quality of the medicine was very, very important for a lot of people in terms of whether it is quality that they were receiving. And we also found out that women tend to trust information they receive at the health centers. And over time, they also started even trusting the information they receive from the community health workers, unlike the situation we had at the baseline when it was just starting. So the quote here explains also how that goes in. Then we found out that a minority of the participants believed in the efficacy of the use of traditional medicine. When we were starting, we thought, would this be a barrier? But over time, we realized that actually what the women, a majority of them, was more like something that looked like medical pluralism, whereby they still take the traditional medicine and then they go ahead to take the SP just as they schedule. But to a limited extent, we found some minority voices that really still take traditional medicine, consider it far more important than the use of IPTp. For the acceptability of the treatment as an SP and the delivery strategy, that's using community health workers, generally what we found out was that the SP and even ANC were generally accepted as necessary preventive measures for pregnant women. Although perceived side effects, people having some perception of side effects, to a few extent can affect some people thinking first of all, should I not? Over time, given the work of the CHWs in the community, most of them generally will accept it. And what we found out was that at the tail end now, at the end line where we are, in the fourth phase of data collection, there was widespread acceptance and appreciation of the great work that the community health workers are doing. Actually, in one of the posts we had in a focus group discussion with pregnant women, you can see them saying they are doing very well by going from house to house to share drugs, and they are grateful. And from the observations we had and interaction, informal conversation we've had, in fact, some communities have gone ahead to even make material and financial donations in appreciation of the great work that the community health workers were doing in terms of helping them to now start taking the treatment, and also in terms of the visible evidence they were seeing in terms of a lot of their children they felt are now less sickly when they are giving birth to, unlike the situation before when a whole lot of people were not taking the SP. In terms of perceived self-efficacy, what we found out was that generally, when a woman has great concern about herself and her unborn child, this motivates her to actually want to take IPTp and other, even go for ANC. But some women would even challenge, even if someone from outside was to tell them not to access the treatment, especially when they understand the import of why it is important for them to take the SP. However, what we also still found out was that women, husbands, tend to play a great role in the decision to attend the ANC and even take the SP, especially even for less empowered pregnant women. In some settings, we found out, especially among a group, we found out that they live more in a patriarchal society where the voice of their men was the most important decider in giving the agreement or decision for them to access that. But this was not general, it was not also widespread. Because we also found out that for majority of women, especially those that were educated, who were more empowered economically, they knew the benefits of SP, and they tend to take the decision more spontaneously, even though they discuss with their husband in terms of husbands being confident. For the attributes of the intervention, what we found out was that one, we realized there was great improvement in access to SP, and women really found out that the community health workers had really helped to encourage more people to take SP. So like one pregnant woman said, who was also a health worker, was that what I noticed is that all the pregnant women are now taking SP, even those that were not taking it before. And this was a common voice that we're hearing across, even in this later phase. This was, when we did the last phase in the phase 3, when we were carrying out to find out what their perspectives were. And also this, honestly, when that's the CHWs come, the pregnant women always collect the drug. And this is something that resonates across. So generally, looking at all of them, as in all the perspective we had from the barrier and opportunity analysis and others, we're able to draw out what were the potential barriers for this innovative method of delivery of IPTp in the community, and not just in terms of having it to be facility-based. And some of them was that for women that have had experience with what they perceive to be side effects, things like vomiting or dizziness, and some others that they mentioned can also be some hindrance. Also found out some social, cultural norms and beliefs were some things that could stand in the way, like some people that believe that there is a certain kind of concussion they need to take for their pregnancy to be fine, and that's the only thing they need. And then people that maybe have delivered before previously using a particular system, maybe using not a Western method of delivery, they still believe in that. We also found out that the pregnant woman's lack of autonomy can also be something that can be a barrier. And then the community health workers, their working conditions was also, could be a barrier in terms of whether they have overload, given that they have to be working from place to place across different terrains that may be difficult. And then in terms of their remuneration, how stable, how steady it is in coming. Actually, it's not remuneration, stipends, they call it, that they pay them. Okay. Then for the opportunities for the CIPTP or facilitators, what we found out was one, the great trust in the SP efficacy across all participant profile. In fact, most of them trust the SP they were getting majorly. And one other thing was for them, as long as it's sustainable, that they are sure they always get it, they don't have a problem. And then involvement of relevant actors from the communities in terms of dissemination activities. Some of the influential actors we had mentioned before have been brought in, and they were now also part of the people carrying out a lot of the disseminations. So we found out that that was also helpful. And then, of course, that the project helps to reduce cost that was associated for people in terms of ANC, or even that, because prior to now, before the Tiptop, they had to pay for SP. So, but now it's for free. So for them, it reduced cost. And then, of course, that a lot of the beneficiaries appreciated the community health workers. This is an excerpt of one of the quotes from one of the participants that shows that. So the other findings we found out was that ANC barriers, access barriers still persisted and could be, I mean, over the whole horizon of the 4 years we've carried out the work. And then what we found out was that over time, people had overcome some of the issues they had in terms of the use of community health workers to deliver such services like the SP compared to using health facility. People are now very, very much okay, and they found it quite helpful in making it much more convenient for them to receive it. So in conclusion, what we found out was that there was generally wide acceptance of the CIPTP by most of the beneficiaries, even though we had some minor reported case of refusal. Some ways we think maybe to overcome some of the barriers mentioned was addressing beneficiaries concerned over ISP side effects, and to get a whole lot of advocacy to getting government and local buy-in for sustainability and continuous motivation of the community health workers, given that the project will soon end and it is now built for potential scale-up. The other ones are stated here. Thank you very much. These are our collaborators. IS Global was also part of the evaluation, and we collaborated with them on the evaluation, while the project was funded by Unit 8, while the implementers was Jhpiego. Thank you very much.
Thanks a lot. Thank you very much, Ogonna. I'm sure there was a very lucid presentation, and I know we can manage with time. We've overshot a bit. So I'm going to quickly, and please go ahead and put your questions in the chat box, and we can take them after the second presenter. So let me have the privilege and honor to introduce the second presenter, Jenipher Angaha. And Jenipher is a nurse. She's worked for over 30 years as a nurse. The first 2 decades she worked in the government facilities as a nurse, and she joined Jhpiego for the past 10 years and worked extensively in different departments of the organization, largely in reproductive health, and also involved in training health workers. And she's done a lot of the major projects that Jhpiego has done lately in the areas of family planning and then community delivery of healthcare with regards to reproductive health in her country. And today, Jenipher will be discussing a debate, as it were, on the effects of group antenatal care versus individual care, as they have observed in Kenya. So it's my pleasure to introduce Jenipher to please take the platform and present her session. It's over to you, Jenipher. Could you unmute yourself, Jenipher?
Oh, sorry. I'm trying to get back my presentation. I don't know if it can be seen from your side.
I'm going to ask Sonia to help you.
Please. Thank you. Thank you so much. So I want to is that okay, Sonia? Sonia, can I go ahead?
Yes, please go ahead.
Thank you. So I want to discuss about group antenatal care. This is an effective way of group antenatal care versus individual care on intermittent preventive treatment of malaria in pregnancy and antenatal care attendance. This is a cluster randomized control that was tried in Kenya and Nigeria. For the ANC, the current ANC experience is that a lot of women have very little time that they're given by the service providers. They have very few visits that they make to the clinic, and there is low quality of services given by the service providers. This is because they need to conduct an antenatal visit, and also an average of about 1.5 minutes of education provided across all the ANCs. Only 22% of eligible pregnant women in Africa receive 3 or more doses of intermittent preventive malaria treatment, or ISP in this case. This means that very little maternal and newborn health impacts are actually done to the women who come to the ANC clinic. Next slide. Next slide, Sonia. I don't know, you are moving it for me. Hello.
Sonia, can you put it in the presentation mode so that you'll be moving faster? Thank you. Thank you, guys. Go ahead.
Thank you. Okay. Now, group NC meetings that were scheduled actually as the recommendations of the WHO, that we got at least we could administer IPTp with each schedule, with which visit offer quickening in the pregnancy, and only should also be given to an should be given under direct observation, that you see the patient taking, or the woman taking the SP, to be sure that the woman has taken the right drug. SP and IPTp are actually supposed to be 40 weeks, whether given up to 40 weeks of pregnancy, and even one dose is not beneficial for the woman until the woman gets at least 3 or more doses. A high dose of folic acid is not administered with SP when it's given, because it may, sorry, you're moving my presentation. Someone is moving my presentation. Hello. Someone has moved my presentation.
It's on slide 4, as far as we can tell.
I don't know if it's the network, but my presentation has been moved.
So what slide would you like us to place you? Slide number what?
Slide number 3.
Okay, we're going to try to put you there. Sorry about that.
Thank you. So you'll be moving the slides for me because I can't see it moving from my end. So basic antenatal group care, we said that when we started the group antenatal care, it was an alternative service, but it was not a group health education. So with the women had to understand education, it was also facilitated women group. And the women who came for the group NC required to be at least 8 to 12 women joining the group so that it would be called a cohort. Next slide. Slide 4. Slide 4. We've talked about slide 4, please. Go to slide 5. Slide 5.
This is slide 4. Okay.
slide 4. Yes, thank you. The objective of Group NC was that the uptake of malaria in pregnancy intervention currently starts at 13 weeks. That is what the WHO has given us. So intermittent preventive treatment of malaria in pregnancy using self-SPs and then use of insecticides were very, very important, and also to diagnose malaria. So our objective for starting the Group NC is that we wanted to make sure that the women are getting the SPs, and it starts at 13 weeks. We wanted to make sure that intermittent mosquito nets are given. We wanted to make sure that the SPs are given, and any patient who had diagnosis of malaria was actually done and given treatment at the right time. Next slide. Next. Thank you. The mode of selection and study inputs at the facility level was that at least for the facility to get that permission of doing a Group NC, the selected facilities had at least 2 or 3 ANC providers and sufficient ANC caseload. That means that we had enough patients or women coming to the facility that would form at least a group of about 8 to 12 women. And then at the intervention and control sites, we made sure that the ANC clinical updates were up to date. We made sure that family planning, counseling was done, and the service providers at that particular site had been trained in family planning, and more so in long-acting reversible contraceptive methods at that particular facility. At the intervention site, facilities only had Group NC facilitators who had been trained for 5 days. And monitoring was supposed to be done at least by the service providers and to know how they could enroll the women to the group antenatal care. Monitoring for fidelity to intervene at the service disruptions was also done. That means that the service providers, before they started any group, they made sure that they had all that they needed at the facility. Like they were supposed to have enough drugs, SPs, and any other thing that they were supposed to use during the group. And then after the meeting, they were supposed to share anything that they were supposed to do in that particular meeting. Next. Next. Thank you. Now this Group NC was actually a study that was done in Kenya and Nigeria. And for Kenya, I must say that it actually improved very much. There was a mean number of IPTp doses, which was higher for intervention versus the control sites. Like in Kenya, we had an up of 3.81 versus 2.72. Which was in the control sites. The IT gone very high because all the women who came to this. Next slide. Thank you. The results for GNC was that it was a higher quality, high value care that increased engagement in the health system. Women in the intervention arm were 2 to 3 times more likely to receive intervention requiring repeat visits, for example, for IPTp and coming back for counseling. That means the women who were in the Group NC were very ready to come back to the clinic anytime they were asked to come. About 96% would choose Group NC for a subsequent pregnancy. And when they were asked, most of them said that for a long time we were not having this kind of teachings, but now that there are teachings, if we got pregnant again, we are very much willing to come back and have these services given to us. They received more ANC, and at least out of 9 of 10 women who received ANC, you could get them coming back in the intervention site as compared to the control site. Next slide. Thank you. This is just a graph to show us how the quality of services were given. We found that during the ANC, Group ANC, we had better care of the service of the mothers. We had better experience from the service providers and even the women who came for the clinic. We had more utilization of services at the facility when the women came for the clinic. That means that we had 2 to 3 more likely women coming for regular visits for the IPTp. we had about 90% of women in group NC who would choose to come back, just like I said, and about 9 out of 10 women who came for the group NC said that yes, during their next pregnancy, they would still want to come back for group antenatal care. Next. Now, women who came for group antenatal care really loved the group antenatal care. Just press on that arrow so that we see what the women said. Go to the next slide. Yes, women who came to group antenatal care were very happy because the women said that it was a safe and respectful way of being attended to. They had very good relationship with the service providers. They were able to get asked questions and the questions were answered. This is because the service providers used a wonder basket, and the wonder basket, the women could ask questions and put questions in that basket, and the nurse would answer the questions with all the other group, and everybody would be satisfied of what they had done. We also had self-assessment. That means that the women who came were doing their self-assessment partner to partner. They were taught how to take the blood pressure and their weight. And also there was self-efficacy for the key behaviors. For example, the women could comfortably talk about family planning. They could share about family planning even to the other women outside the group. For the service provider, she was so excited about the group NC because she said that during the group NC, she was able to do very good organization of her work. That means that she prepared early enough because she knew that today I'm going to have about 15 to 12 or 8 to 12 women coming for the group NC. So this means that the women were going to have the best information given by the service providers. And also there was good respect between the service providers and the women. And also there was good relationship that was between the service provider and the women. And the service provider even said, yes, now I know the women by name. I can talk to them by name. I can call them by name because when they come in a group, I'm able to have a one-on-one interaction with the women. So the women are also empowered on what they were supposed to do, and that actually improved their literacy very much because the women could freely talk about family planning. They could freely talk about their birth care. They could freely talk about what was expected and how they're having their diet. Next. Next. Yes, the provider said, now I know the names. So the group NC in low resource setting was that it improves IP and SP coverage in the facility, and then may improve ITN use for the infants. It also increases ANC attendance and the experience of care for women and the providers. The results support further study of group NC as platform to improve coverage of other interventions. So group NC was actually improved so much on IPTp because you are sure if you started with 10 women, then the 10 women will still come back and get all the IPTPs up to 3, 4, and even the 5th IPTZ from the experience that we had during this time. Next slide. Thank you. This is the continuation. Now this continuation is actually based on one of the facilities in western part of Kenya, that is in Kisumu County, a facility known as Katitu. In this facility, there was ANC in the first trimester, about 65% to 85%. This was actually noted during the group antenatal care. There was also an improved uptake of 4th ANC, which rose from 40% to 80% of care. We also had an uptake of skilled service delivery. What we were sure that all the women who came for the group NC came to deliver at the facility site. None of them went out to deliver by skilled by outside the hospital. And then we also had a reduction in number of perinatal deaths. This is because the women were taught during the classes And when they were taught about the danger signs of pregnancy. They were told about the problems of pregnancy. They were taught on how they should come back to the facility if they have any problem. So this actually assisted in reducing the number of perinatal deaths. There was also a reduction in preterm deliveries because the women were told about any signs of danger, and in case of any problem, they were able to come back to the facility early enough. And then the service providers were able to account for all the mothers coming for ANC and the outcome of all the pregnancies. That means that if a service provider had 12 women coming for Group NC, then this service provider would be able to know that out of the 15 or out of the 10, one has not come. So I need to get a follow-up and know how come this particular woman has not come to the clinic. So they were very accountable for these mothers who are coming for the ANC clinic, and even their pregnancies, they really wanted to know how their pregnancies were going to be taken care of. Next. Future direction. This is a service delivery of one of the service delivery officers who was actually just showing how they use the cards. And we have the scale up that are to adapt and optimize group antenatal care. And then in this era of COVID, the group antenatal care in some facilities did not take up so well because we wanted to avoid that crowd of the women coming together. But by and by, we are going to see how we can start the group antenatal care or continue the group antenatal care in this era of COVID. And then GNC implementation with the focus on IPTp coverage in the President's Malaria Initiative is also something that we are thinking about. As we look at treating malaria, we also want to see how can the women who are pregnant make sure that they get all the 3 IPTPs or 4 IPTPs, and how can they get the nurse comfortably as we also continue managing in the President's Malaria Initiative, Impact Malaria. Then we also have an additional Jhpiego performing plans. There was a plan that Indonesia, Kenya, Mali, Ethiopia, and Afghanistan was supposed to start Group NC. I'm not sure whether they have started, but that was something that was going to be good because in Kenya, we enjoyed Group NC. It was very good in Western Kenya and in Machakos, and that is something that we can move on and do the Group NC. Next slide, I think is the last one. So I want to acknowledge all those who assisted us during the Group NC. We had the Belinda Gates, we had the GNC, and the John Hopkins, who are very, very much working. And for Kenya, I was actually working under Jhpiego to do this particular Group NC, something that has been very good, but the country is still following it up just because of the COVID situation in Kenya. The last slide is just talking about my next. Thank you so much. That is all I had for you. If you have any questions, I'll still respond to them. Thank you.
Thank you. Thank you very much, Jenipher. And thanks, Ogonna. We've had 2 amazing presentations. We'll be moving forward now to the Q&A section. Please, if you pose any question in the chat box, that would be great. If you have not yet, you could do that or raise your hand and we will identify you to ask your question. If you would say which of the speakers you would like your question to be addressed to, that would be helpful. I would like to start by, as you put your questions or put up your hands, I'd like to start by once again congratulating the speakers for very lucid presentations and for very, very relevant pieces of research work that they presented this afternoon. So we have 2 questions from my colleague Regina Ivanovich, who introduced us initially. These are critical questions, which I think we can start with while you fill your own questions. And this is for both speakers. The first one is, what is the likelihood that, what is going to happen, in terms of feasibility when your projects end, how sustainable, in terms of sustainability, what's going to happen to your projects at your current project sites? What do you anticipate? What are your worries? What are the activities put in place? So we're going to go first and ask Jenipher if you'd like to go first, then Ogonna. And if you'd like to ask if there are if these approaches on your own assessment, given the health systems that you operate in, are these approaches you described scalable? Can they be scaled up easily? I mean, we wanted to get your opinion on that too. So over to Jenipher, if you got me.
Thank you very much. Thank you very much. Now for the scale up, as we were coming to the end of the group NC study, we had actually started the weaning of the service providers at the facilities, because one thing, we trained the service providers at the facilities, and our training meant that they were supposed to continue carrying out the group NC in their facilities. So when we worked out, we actually started weaning them, and we could let them, we could just go there to observe how they could do it. We could want to see if they were able to train others. And for Kenya, I remember in Kisumu, we were even able to train some more providers. And this was an initiative from the MOH staff themselves, the county government was able to train the staff on their own so that the staff would continue carrying out the group NC. So as we completed the project, we still had that program going on, but done under the Ministry of Health or under the specific counties. So it was done, it's still there. It's only that because of the COVID, it had to stall a bit because we had to get out other now formats of how to do it better. But it is something that was still going to be done. It is even done in some facilities in Kisumu. Thank you.
Thank you, Jenipher. Before I pass it to Ogonna, I don't know if you would like to also say, in terms of all the components that influence scalability, do you think this could be scaled up to other parts of the country, and how feasible would this be? Jenipher.
Pardon?
So
Pardon?
Do you think this intervention, how easy will it be to scale it up to other parts of the country?
Thank you. Now for the other parts of the county, I remember when we were doing the group NC, it was Kisumu and Machakos, but we have neighboring cities or counties that were able to come and see what we were doing. So some of them have been learning, and this is something that's still under the reproductive health, and the reproductive health unit has actually taken it very positively. And because of the results that they saw in Kisumu, they would want to train people in other counties. So that is something that the reproductive health unit in Kenya is actually thinking about.
That's so great. Go ahead, please. Sorry, finish your comment. I thought you stopped. Great, thank you. Ogonna, it's your turn now to tell us what you think would happen when your project ends in Nigeria in terms of sustainability, and also to tell us how scalable you think this intervention could be given the standard type of health system you have in Nigeria. Over to Ogonna.
Okay, thank you, Prof. For me, I think it's very, very scalable, especially given that currently the country as a whole, the current policy by the National Primary Healthcare Development Authority, which is now looking at more, development of what they call the CHIPS, community health influencers, provider services, who are like some community health resources that are there. So all this is showing is that it is potentially possible that community members can actually trust that such people can even deliver commodities like SP, which is for maternal and child health, maternal health care. So, with that, it's easier because the big challenge that is there is about remuneration or stipends, as you call it, for the community health workers. The lay persons are going to be used. So that I guess is where the challenge comes in terms of having government to really have a strong buy-in that this is quite key. Because, there are two things that happen apart from their distributing the SP, was that it appeared that people perceived that they also helped to improve, to have more people going for ANC, which is quite great, because there are other great services that needs to be done at the health facility level. Again, with the current move away to provide more funding for health, potentially this is also what I would suspect will be a very cost-effective way to improve and get this done. So I think generally it is far much more easier to scale it up, given that the government already is also thinking of moving in the direction of having an established, formalized cadre of people that are like lay health workers that you can always use for such services. So I guess that would take care of it. Thank you.
Thank you very much. But just to find out how much of the buy-in of the government do you have at the moment, at the time of implementation? Do you think there's sufficient buy-in in conceiving this project and the cost of implementing it? Would it just be like you're handing data over to government to run, or are they already involved in the process of implementing this?
Okay, well, just a disclaimer, we were not the implementing partners, which is Jhpiego, who were directly involved, but from our interaction from the field, we found out that the governments were really taking in from the onset that the work was being carried out. So, and then there's lots of dissemination meetings we've had, where we've had high and representative from the government and other partners. One thing I know is that also, given that this is being implemented across 4 countries, which makes the evidence to be stronger when it comes out, because looking at the socio-ecological model, where it was clear that at the political level, that both state actors and even international organizations like other international organizations that can bring about the weight of evidence to bear, I believe that greater engagement with them would actually ensure that this is taken up. But I know from lots of the engagements, I mean, informal conversations we had, that the government were actively interested in getting it done. Thank you.
Thank you very much, Ogonna. This question is from Paolo and is for Jenipher. The question is, can you please clarify on which was the target group for their intervention? Were there women of reproductive age or only pregnant women who were looking for ANC services? So who were the target groups for your intervention? Were they all women of reproductive age or only pregnant women who were looking for ANC services? Jenipher?
Thank you, Martin. Our target group was actually the pregnant women who came for their first ANC visit. And so we were recruiting the women of a gestation of below 16 weeks and putting them in cohorts. So any woman who would come below 16 weeks, we put you in the first cohort so that you continue having the services after every week when you come. We would not take a woman who was more than 24 weeks in the cohort, because then the person will not actually learn so much. We had some information that we wanted to give to these women at the early age. And this early age was, they were supposed to know about the problems in pregnancy. They were supposed to know the danger signs. They were supposed to know how they're going to do family planning. Actually, the teachings were in sessions. And so you would not get a gestation of 38 or 36 to come in the group. So we started as early as about 12 to 16 weeks pregnancy. And the first attendance in the pregnancy. Those are the cohorts you are forming.
Thank you very much. Now, we have one more question, which I would very kindly ask Regina to ask you directly. Yes, Regina, please, could you ask them the last question to both speakers?
Yes, there was an interesting experiment about 10 years ago in the UK because they were frustrated. The staff knew what should be recommended. People were aware of the vaccine, but there was poor uptake. and how they intervened. It was not a trial, it was actually implementation and evaluation. How they intervened, what was by putting a pay for performance, very small amount of money that went to the clinic, not to any individual nurse or doctor or health extension worker. And then gave them a reward that they shared and decided how it would be used on their own. And I'm wondering if that kind of approach would be something that would work in these areas.
So I'm sure Ogonna and Jenipher understood that Regina said that somehow this UK program tried to supplement resources at the facility level for collective use, not for individual health workers, and that appeared to have helped. How would you consider this to play in various scenarios? Ogonna first.
You're muted.
Muted. Okay, please, Ogonna, unmute yourself, and then anybody can go first. Jenipher or Ogonna, how would you consider supplementing facility capacity with some finance or some other form of incentive for the collective, facility personnel? How would it help with the interventions you have presented?
I didn't get your question well. Did you say giving incentives to the healthcare workers?
Well, not individually, but for the facility.
Yes.
The kind of supplement for the facility. They could use it for anything that would help their work.
Okay. Now, I know what would really be a barrier for the healthcare providers to feel comfortable working would be the equipment that they were to use. Actually, for the facilities that were doing Group NC, we motivated them by making sure that we had all the equipments ready for them to work. Like we had the blood pressure machines. And we are saying the women were taking blood pressure machines from one another. So they were pairing themselves. So we had to get at least 4 blood pressure machines for the 12 or 15 women in the group. So that made the work of the service providers very motivated. The women were also taught how to take their weight and they could chart them. That motivated the healthcare providers, and it looked like they were actually working together. It was an interaction. So that is actually what motivated. But we do not motivate them by way of giving them anything like money or anything else. We just motivated them by making sure that they were updated on the Group NC, the model, because it was not a model like any other, where you just bring together women and to start talking to them any information. We were giving them specific information at a specific gestation period. So the service providers were very much excited that every time they meet the women, they have something very specific to tell them. They have blood pressure machines, the women will take the blood pressure, the women will weigh themselves. So that is actually what was motivating the service providers. Actually, them to the right knowledge.
Thank you very much, Jenipher. I will just have less than a minute. Ogonna, would you like to say something?
Well, yeah, I think also for Nigeria, I mean, in our own context, I believe that it would work. I think the only thing would now be sustainability at the end of the day. But yeah, it will motivate health workers to really get to do the job, especially if you also have some kind of performance-based indicators at the end of the day. Thank you.
Thank you very much. Before I pass you back to Regina to close us, I'd like to thank you two very much for such excellent presentations and for the audience for having been engaged with us for this long. Over to Regina as we close.
Thank you very much. We hope everyone enjoyed this session of our monthly webinars, and we hope to see you in November for the next session. We will be sending out a save the date and the topic. Hello? Hello, can you hear me?
Yeah, we hear you very well.
I can hear you now.
Okay, thank you. So we hope you enjoyed this seminar. We will be sending out save the date and the topic for the next seminar in November. And Sonia will be sending out a follow-up email with the recorded presentations and the summary report of today's presentations. So I'd like to thank the panelists and our chair for an excellent session, actually, and I'm looking forward to seeing how it's captured further by more people as it's posted on the open access seminar series. So thank you very much, everybody, and have an excellent day.
Thank you very much. And bye, everyone.